So I have the privilege of talking about robotics, and I have to argue the pro point against Dr. Senagore, which is not going to be an easy argument, but I'll try my best. I am an assistant professor at Johns Hopkins. Good morning from Baltimore. So is robotic surgery better than laparoscopic? It's been argued from the inception that robotic surgery is a solution in search of a problem. And I will try to show you today that that's not the case. The only commercially available system today in the world is the Da Vinci system. It's made by Intuitive Surgical. This system was FDA approved in 2000, and it's gone a number of advancements and a number of new models, and then the new most recent platform that has actually been released is the XI, which just came on the market a couple of months ago. It's a master-slave system where the surgeon is the master that sits remotely from the patient, and the actual system performs the surgery close to the patient. I think most people who are logged in today have seen the robot and used the robot, and its new platforms have actually come up with many advancements, such as staplers, vessel sealer, blood flow, etc., etc. These are the systems that are actually in place now. The S, I think, has pretty much been faded away. The SI is what most hospitals have today. It has HD vision, the console, finger clutch, etc., etc., and they introduced the stapler in the Firefly recently. And the XI actually comes up as a very much of an improvement for the colorectal surgery, because the way that you dock is completely different. The way that the ports line up and the way that the arms line up is completely different. So even the placement of your ports is different. So it's supposed to have easier docking, more wider range to cover, and hopefully with one dock you can do the entire operation for a low anterior resection. So what are the advantages? Essentially, we all know about the advantages of minimally invasive surgery in the short term. The robot has all the advantages of minimally invasive surgery. In addition, it has a better camera. It has much easier intracorporeal suturing ability because of the wristed movement of the instruments. The surgeon controls the camera, so you don't have to have a skilled assistant trying to tell them, look right, look left, look up, look down. You definitely have more consistent and better retraction, especially in the pelvis. Something that we don't talk about a lot is reduced surgical fatigue, which is, most surgeons who do a lot of laparoscopy end up with back pain, strains, etc., etc. Sitting on the robot is much more comfortable. You're not sitting or standing in funny positions, and that's, I think, a very important point that we don't talk about too much. And potentially improved outcomes, and we'll go through some of these. So what are the surgeries in colorectal that have been done robotically? Well, you name it and it's been done, including presacral cysts, but the big operations such as right colectomy, left colectomy, total colectomy, any rectal surgery, it's all being done. But does it all make sense? I'm not sure. I think the robot is definitely made to work well in the pelvis. I think the company would like to expand it to work well in the abdomen as well, and that's part of their new platform. The pelvis lends itself to robotic surgery because it's a focused area. The robot gives you, again, consistent and retraction, which is much better visualization, and the two operations that really make sense when you're looking at the robot in the pelvis is for benign disease such as rectopexy, and then for rectal cancer. Rectopexy is actually, a number of studies have shown that it's safe, it's feasible. This is a study that shows that from a single institution that they looked at 77 patients, the conversion rate is very much acceptable, with a very acceptable recurrence rate, 12.8, which is equivalent to any laparoscopic data, and that's actually long-term data. What about rectal cancer? Well, rectal cancer offers us a special challenge. Number one, a lot of our patients have neoadjuvant therapy, so it makes the surgery maybe more challenging. We're looking at preserving the sphincters and going as low as possible. We have challenges with laparoscopy today with angulation, staplers, and very importantly, the specimen and the circumferential margin status is very much equated with survival and local recurrence. So that's really the key in rectal cancer surgery. So again, the quality of the specimen, we believe, translates into improved radial margin positivity, or reduced radial margin positivity, and therefore improved local recurrence and survival. So, can it be done laparoscopic? Sure, but I think we have all heard the sort of preliminary results or the concerns of the Z6051, which is the trial that has been done with laparoscopic versus open cancer, and the challenges with laparoscopy. So laparoscopy may not offer you the same quality as open. We don't know formally the results of these yet, but it is to be determined. We don't know exactly how the robot also fits into this. So a few studies actually have looked at this, and this is a study from Korea. They looked at 56 robotic low anterior resections, and they compared them to 57 laparoscopic low anterior sections. Now, the operative time was about the same. This is from Korea, so maybe you can argue their BMIs are a little bit different to what we see in the United States, and that's why the surgeries, in terms of timing, is about the same. The one thing that you'll see consistently in all these studies is that conversion rate is better in robotic surgery. In this case, it was 0 versus 10%. And what's important in this study is when you look at this specimen, that the robotic arm had more complete circumferential margins, and definitely equivalent or better, nearly complete, and had no incomplete ones. And this was statistically significant. And I think that's where the key is. That's where robotics, if anywhere is going to make sense, is in this indication. Again, this is a study from Europe. They looked at 50 robotic total mesorectal excisions versus laparoscopic, and the circumferential margin, which they defined as less than 2 millimeters, was none in the robotic arm versus 12% in the laparoscopic arm. The conversions, once again, 0 in the robotic versus 12 in the laparoscopic. Now, this study also looked at functional outcome, and when they looked at urinary, it actually became the same after a time, but erectile function was better in the robotic than laparoscopic arm, even at 1 year, arguing that potentially that you have better visualization, better dissection, better outcome. What about, this is probably the largest controlled open versus robotic versus laparoscopic. This came out in Annals of Surgery a couple of years ago. This was a single institution retrospective. They looked at 165 patients in each arm, and they used propensity scoring to match those patients. The tumors were all located within 10 centimeters of the anal verge. And when you look at the outcomes from this study, the positive margin, again, was improved in the robotic when you look at it versus open. And when you look at other postoperative outcomes and intraoperative outcomes, such as EBL and conversions, the conversion in this study did not come out as a positive, but in most other studies that you look at, the conversion rate is to some extent improved with the robotic, because I believe that you get a better dissection, a better look at the pelvis. The wound infection rate was significantly different for the robotic, and so was the length of stay versus both when you compared length of stay with open and laparoscopic. So the conclusions from this study was robotic surgery showed better recovery outcomes than laparoscopic with regard to time to resuming soft diet and length of hospital stay. And robotic surgery may be effective in an effort to maximize the advantages of minimally invasive surgery in the management of mid to low rectal cancer. Finally, this ROLAR is a randomized trial that actually has been performed in multi-institution, multinational, that was sponsored by the United Kingdom. The results were, preliminary results were just announced or just discussed at the latest American Society of Colorectal Surgery meeting. They had identified 400 patients, and they randomized them 1-to-1, robotic versus laparoscopic. They had a 30-day follow-up, 6-month follow-up, and they plan to do a 3-year follow-up. And this was to look at, the primary endpoint was actually conversion rate, and then they also wanted to look at circumferential margin and then 3-year local recurrence rate. In addition, they actually had cost, safety, and quality of life endpoints. None of these have actually been reported to this point. Definitely not the quality ones. So, as I mentioned, it involved 10 countries. There were 40 surgeons there, and there was no difference in gender, BMI, neoadjuvant therapy, or type of surgery that was performed. And actually, they've closed to recruiting patients. They're just actually following the patients in order to report their data. So their preliminary results actually show no difference in circumferential margin in this case, no difference in lymph nodes. However, there was a tendency to have higher conversion rate in the laparoscopic versus robotic. That was 12 versus 8%. And this was specifically in male, obese, low tumors. So in the difficult pelvis, this actually may offer you an advantage even over open in terms of seeing and completing your procedure and getting low down in the pelvis. Now, yes, you do see longer operative time in robotic surgery, but in this case, in this trial, it's only about half an hour more. There was no differences in complications, no differences in length of stay, and similar mortality in both groups. So that was the case for rectal surgery. I believe that because of the better visualization, better retraction, you actually have very much an improved in circumferential margin positivity and potentially short-term outcomes. So what about colon surgery? Does it make any sense? This was a study from our institution that came out last year in JAMA Surgery, and actually it's one of those database studies. They looked at robotic surgery versus open versus laparoscopic in a large cohort. This is the national inpatient sample, and there was many patients, as you'll see next, included. And what they showed is that laparoscopic surgery, and which is something that we all know, offers improvement in complications, improvement in short-term outcomes, faster recovery, faster discharge. However, does that translate itself into robotic surgery? And it's a little bit difficult to see this when you actually compare laparoscopic to open. Everything is significant. You look at mortality, complications, morbidity, ostomy rate, length of stay, etc., etc. Everything, if you look at on the right side, all of them are statistically significant. However, when you compare robotic surgery to laparoscopic surgery, the complications, the mortality, stoma rate, all of them are equivalent. There tended to be a little bit improved in length of stay, but this was not statistically significant. Actually, when you look at it, it was 4 days in either side, and it says 0.05, but that's actually not statistically significant. The one thing that did come out that was statistically significant is that robotic surgery is more expensive. And when you look at it, it's because it has much higher consumables, both the capital of buying the robot as well as the disposable instruments that you use with the robot. It ends up being more expensive. What about if there is any advantage in doing colectomies robotically? Well, I already argued earlier that the robot has, because of the wristed instruments, it has an easier way an easier tool to suture intracorporeally. And is there an advantage to that? Now, most of us don't need to do intracorporeal suturing. Most of us are probably not very skilled in doing intracorporeal suturing. MIS surgeons tend to do more of that type of procedure. However, Dr. Barry Salke a few years ago looked at right colectomies and compared right colectomies with intracorporeal versus extracorporeal anastomosis. And the idea is that you're not actually stretching the mesentery to do your anastomosis outside. You're doing you're making an incision much smaller than you'd have to do your anastomosis. You can make an incision remote from the umbilicus and take it out in the Pfannenstiel position. And in general, they found that they had improvement in narcotic use, improvement in length of stay, and the morbidity was significantly less when it came to intracorporeal versus extracorporeal. Now, that concept clearly might be much easier to do robotically, and there is a study looking at this. And this study came out of Italy, again, very recently, just was published in Surgical Endoscopy this year, and they compared robotic intracorporeal versus laparoscopic extracorporeal versus laparoscopic intracorporeal. So 3 arms, and they compared each one in terms of conversion, length of stay, and outcomes. Actually, there was no difference really in the outcomes in terms of complications. However, there was a much improved, significantly improved robotic versus extracorporeal, which is 4 days versus 7 days. The difference between the laparoscopic intracorporeal and the robotic intracorporeal was not statistically significant. Also, time to first flatus was significant when compared for both. So performing a robotic offers significantly better perioperative recovery compared with extracorporeal, with a significant reduction in length of stay. So in conclusion, when you look at robotic surgery, rectal versus and colon, I think robotic surgery actually does take a little bit longer to perform. It does cost more. However, it enhances the surgeon's ability to complete the case. It offers the surgeon more comfort and potentially less fatigue. And the cost benefit will shift as there's more competition in the market for more robotic platforms. And I think once we can get the cost driven down, then it will make then it will be very much a viable solution, even sort of on a more national or a more global stage. So definitely the robot is here to stay. So when you compare laparoscopic to robot, this is what I'd like to look at it. Just because it costs more, it doesn't mean that we shouldn't do it. So laparoscopy offers you all the advantages of a BMW. It drives beautifully, it does very well, it gets you there, beautiful handling, but it's not a Rolls Royce. So that's what robotics is. More expensive, but you get more for your money. Next slide, please. Thank you.
Thank you very much, Dr. Safar, for this excellent review and excellent conclusion. We will go next to Dr. Tony Senagore from Case Western University.
Let's start at the beginning, because I'm a big believer that words mean things, and I think as we have this kind of debate, we should define what we're really talking about. And you can read the slide here, but I think we have to be careful about what is robotics. In reality, a robotic device is one that works autonomously. That really is not true in the case of this platform. It's much more akin to a drone in that a human being drives the device, much like a human being drives the laparoscopic instrumentation. So I think, again, we have to be very clear, not that it doesn't mean that the device may or may not be enabling to your technique, but it still is human-guided surgery either which way. So I think these are really the platforms of debate. And I think if we're going to define new technology, and particularly in today's economic environment, we're going to have to be a lot better shepherds of resources as we go. And so clearly I think this is just human-guided surgery, one way or the other. And the comparisons really need to be between robotics and straight lab. Comparing against open data really is, or even hybrid procedures, is really not a fair comparison. I think everyone in the audience would stipulate that laparoscopy is superior to open whenever it can be done. Clearly the procedure is being adopted for a variety of reasons. I'm going to show a little bit of data about learning curve, because I think in the case of robotics, I think there is a distinct and separate learning curve compared to laparoscopy. And it's amazing that cost doesn't seem to matter, because it seems to matter to everyone else, particularly the people that pay us. So I think we should be very careful about how we look at our cost structures for surgery. And then at the end of the day, it's really about our patients. Did we treat the disease better? Did they recover better? So you've seen some data about laparoscopy, and just to remind everyone, laparoscopy is clearly better than open. Lower complications, lower cardiovascular risk, on and on and on, lower wound complications. So clearly the platform for the future is about minimally invasive approaches, not about what is driving the instruments. And long-term complications are better, primarily related to wound, really. Much lower rate of hernia in laparoscopic procedures because of smaller and alternative extraction sites, but probably a reproducible lower risk of small bowel obstruction. So again, some of this is deja vu for me, since I was there really at the beginning of laparoscopic surgery, because I heard a lot of the same arguments about hand assist laparoscopic surgery. It was easier, better, faster, better, easier. But here's some data that compares two fairly large institutions, straight lap versus hand assist, and I'm not sure someone would walk away with the construct that hand assist is maybe even equal to straight lap, let alone superior. So again, we need to start comparing the same outcomes in the same fashion when we look at technologies. This is some data that we published when I was at the Cleveland Clinic on learning curve, and it's pretty much the reproducible learning curve of any surgical procedure. You start out with easy cases, and then you get pretty good and you get pretty confident, and then you do more complex cases and you're not so confident and not so good, and then you master the requisite skills and you're back actually to your baseline performance. And the numbers of the cases are going to be fairly consistent to what you see in the laparoscopic data. It's somewhere between 40 and 80 cases, depending on the procedure, depending on the expertise and training history of the participants. But there is a reproducible curve that is fairly substantial case volume, and I would submit that 40 colon resections or 40 rectal cancer resections is a large volume of work for the average surgeon. This is another way to look at it, the learning curve, is when did the fellow become autonomous? So you can see that the time stayed about the same. So with good teaching and good monitoring, you can achieve the same results even early in your experience with a trained person at your side. And you can achieve those same results, whatever your baseline function is as you as a surgeon, your own operative tempo. And that curve is about the same thing. It's about 50 to 60 cases in the case of colorectal surgery. This again looks at hand assist. This was one resident against himself. In this case, it was Brad Champagne. Half the team attendings did hand assist, and the other half did straight lap. And again, you can see the results were, arguably at least the same, although the completion rate was better with the straight lap compared to hand assist. So let's look now at some of the robotic data. So this is a good paper from a very experienced laparoscopic team that looked at their laparoscopic procedures and then their subsequent robotics. And it's sort of the recurring theme of all of the robotic literature, really, is that the OR times are significantly longer. The clinical outcomes are about the same. And so if you have someone who's very experienced in laparoscopy and it still takes 40, 50 cases to try to get back to your learning curve, this would imply there are different skills to drive the robot compared to the way you drive your normal laparoscopic instruments. And that shouldn't be forgotten if we're going to think about training issues. The meta-analysis, again, recurring theme, it just takes longer. There's a couple of series where they approach the same time laparoscopically, but almost across the board, the consistent data is the operative time is longer. So if you look at this, which is a really, I think, good team, because these folks are very skilled both in robotics and laparoscopy. So they would have every ability, I think, to directly compare their results. And when you look at again, the outcomes are the same. Pathologic outcomes, no difference. The learning curve of the robotic low anterior was similar to laparoscopic and again distinct. So if we're going to think about training opportunities, a trainee may only be able to technically invest in one to become proficient, straight lap or straight robotics, something that's going to be a complex issue when we think about our training paradigms in surgery. You don't need to read the eye chart, but this sufficiently says that it's been done in rectal cancer. This is the purported benefit. I think if one was going to stipulate any potential advantage for robotics, it would be in the distal third rectal dissection. Now, the challenge with that is, this is much like the generals always fighting the last war over again. There is now a new distinct competitor in both laparoscopic and robotic rectal cancer surgery, which is the TATME, that really improves the ability to do that distal dissection with even less trauma than either of the laparoscopic techniques and still preserve the minimally invasive outcomes. So the data is early, but I would suspect that the TATME, much like the TATA procedure that Dr. Marks proposed many years ago, is going to really expedite our ability to manage these distal rectal cancers in a minimally invasive fashion. It just shows the same outcome here. So what about clinical outcomes? Again, the recurring theme when you look at either single site or large data sets, the cost is routinely higher with laparoscopic without any significant improvement in clinical outcomes. So if you were a consumer, although the Rolls-Royce would look very nice in my garage, I would be very happy driving the BMW because I think I can still get to work just on time with that car with a lot less carrying costs. Clinical outcomes, again, when you look at the outcome here, there was at least a $400 difference in resource allocation, and some series have shown at least $4,000. Here's one with $4,000 difference. It's very hard in an environment of fixed reimbursement to argue that you're going to take $4,000 of your margin and put it towards an outcome that is no better for your patient. That's going to be very hard to be economically viable in the long run, and I think there would be no argument that would suggest that colon resection can absorb this kind of cost difference with the state-of-the-art of current laparoscopic techniques. Again, back to the learning curve issue here. Again, it looks like it's 30, 40 cases. Cost structure is higher. Again, a recurring theme that is just more expensive, takes longer, and it takes a different amount of time to learn. This is one of the major reasons. If we forget the capitalization cost of the robot, this is a recurring cost of disposables for the procedure. Now, you may not use all these things, and so you may be more efficient, but the current state of laparoscopic surgery is for most of these things, aside from the energy devices, which are obviously reusable, my laparoscopic instruments last 500, 600, 800 cases. So the cost efficiency of using those laparoscopic instruments far exceeds the robotic disposables. And it's never the money, it's just the money. I'm sure that as chair of surgery, you have to start looking at outcomes and performance. What this slide shows is the contribution margin per length of stay and per hour of OR use, and the blue balloon is the balloon you want. More money, less time, less resources. It's going to be pretty hard to be the salmon-colored one in the left lower quadrant unless you can really show a value proposition. This is a very interesting slide because, and you may not be able to read it, but I'll kind of walk you through the methodology. This is by Rick Satava, arguably a guy on the cutting edge of technology and probably a pro robotics guy if you asked him. But when you look at how, and this is prostate, this data. So the only way that the robot made money, it never made money on any procedure. What it made money in is the theoretical benefit of reducing the length of stay from open prostatectomy and then backfilling that bed with another operative procedure. So that's pretty optimistic, that you really are clearing the way for your colleagues to make the money to support your avocation. I'm not sure that that's an economically viable story either. So again, as we think about robotics, although it seems really sexy, I'm not sure that we have an autonomous robot to do our surgery. That would probably be a help to me, someone to actually give me guidance. But I think we need to start comparing apples to apples as we look at the outcomes. There's nothing wrong with investigation, but at a certain point, it needs to stand on its own legs. And I will clearly submit that robotic surgery is being adopted, but I'm not sure what the reason really is at the end of the day. At some point, just like we had to do with straight laparoscopy, we had to declare at least a tie, and it turned out we actually declared victory over the open version of surgery. So I would submit that if we're actually going to look at this in the future and forget everyone's bias, I think we need to define a cost-benefit ratio that is reproducible, clear definition of what technical issues we're talking about. Let's base it on things that really matter. Did our patients get better? Was the disease managed better? Was the cost efficiency better? And compare it to laparoscopic with current management plans, because a lot of the retrospective robotic data is using more old-style post-operative care, which impacts on the length of stay issue. So in a perfect world, we'd have prospective randomized trials, and probably the best one was ROLAR, which suggested in experienced hands there was no real advantage to robotics. And it'll be interesting to see their cost data when they report it. So I'll stop here, and I'll look forward to the questions, and thank you for the audience for participating.
Thank you very much, Dr. Senagore. Very well, very evidence-based arguments against robot, and we appreciate this very nice presentation. We really welcome the questions at this point, but in the meantime, we do not have any. But I would like to go back to Dr. Safar for a 3-minute rebuttal and see if he has any additional comments based on Dr. Senagore's presentation. Dr. Safar?
Thank you. So the only thing I would say is I think Dr. Senagore was there at the beginnings of laparoscopic surgery, and I have no doubt that when he first started doing laparoscopic surgery, everybody said this makes no sense. Why can't we just do it the old-fashioned way? We know that this is we've been doing this for hundreds of years or tens of years, and we know the outcomes and it's consistent, and why would you try this? So I think when you have new technology, you're always going to have someone who's going to doubt you. You're always going to have someone who's going to question the use of it. Now, this technology happens to be more expensive. I will grant you this, but I think there will be a time where the cost will come down and it will be very marginal in terms of improvement. I do think it does offer significant improvement in the pelvis because it does give you much better retraction, visualization, et cetera, et cetera. I don't know about the stapler. I have not actually used the robotic stapler myself. I know that they've introduced it even with the new platform, the XI, which I actually did my first robotic case on the XI yesterday. So I think the cost is very much an issue. I think we live in a cost-sensitive environment, and I think we have to be aware of that. But I do also believe that as other companies enter the market, and as the market pushes the Da Vinci or the Intuitive, even if they're going to be the only ones in the market, as they push them harder, the margins will get less. You know, right now they have a monopoly. They're the only ones in the market. They can name their price, and they've decided to sort of go into every business. They sell staplers, they sell everything. So that's a separate issue. But I do think that will come down.
Thank you very much. Dr. Senagore, we can go back to Dr. Senagore now.
So I guess it comes with becoming chronologically advantaged to have history explained to you when you actually live through it. I will tell you that the arguments really were not the same from a guy who was there at the beginning. Yes, there were a lot of naysayers at the beginning. We had to do a lot of proof. That's what led to the cost trial. But I will tell you this, the recurring theme from almost the very beginning is even though the operation may have been less efficient, the outcomes were incredibly different than what everyone was used to seeing with open surgery. That is simply not the case with robotics. There is no burning platform for a patient-centered advantage for the adoption of robotics. And I'll stipulate that with the rectal cancer, I think the TATME is going to be actually a very incredible, empowering technique that's going to enhance distal rectal cancer resection for both laparoscopic and robotics. So at that point, it'll be equivalent. So again, I'll throw out the same challenge. We can't say that, oh, it's new, so it's got to be better and good. At some point, it has to stand on its own legs, and I haven't seen those legs yet.
Okay, thank you very much. I would like to also comment that when Dr. Sam from Germany in 1980, when he first performed his laparoscopic appendectomy, his colleagues thought that only a person with a brain damage would perform laparoscopic surgery, but and then they even went further to order a brain scan for him. But those days are gone, long gone for sure. But definitely what Dr. Senagore articulates is very correct as well. We do not have any evidence at this time. I do have also Dr. Jeffrey Pansky here, and I believe he would like to make a comment here.
Yes.
Dr. Pansky.
Folks, I think that was a great debate, a great discussion. I have been a naysayer about the robot since the very beginning, but I have to tell you some reflections I have. In the area of the prostate surgery, which was a leader in robotic surgery, you could argue that the people who could do laparoscopic prostatectomy could do it just as well with equal results and equal outcomes and lower costs than the people who did it with robotics. No question about it. So why did it grow? And it grew because it was a facilitating technology. The advent of the robot in prostatectomy allowed more people to do the same surgery at an earlier stage of their technical ability than the other way, to do laparoscopy alone. I think that we also have to look at the facilitating ability of the technology. It allows people to come in a little bit earlier, so it expands the availability of this type of surgery. One other thing to think about. The other point is that this is a technology in evolution. And Tony, I really do believe that just like you can get cars now that keep you within your lane. Two of my sons have Teslas. They push a button, it stays within the lane. They don't even have to touch the steering wheel. I think that the robot will improve as we watch it. It will protect us. It will facilitate and reduce complications. So I think we're in evolution now, and as much as I'm a naysayer, I have to watch it develop. I think it will develop.
Thank you very much. I know also Pennsylvania, Dr. John Marks is connected, and his name was mentioned by Dr. Senagore as well here. Can we get connected
Actually, to be clear, I mentioned his dad.
Okay. I guess he's not there today. Any other comments from any other centers at this point? Dr. Shah? Okay, we are also connected to Mount Sinai Barry. Dr. Salke is Barry connected?
Sure, it's Dan Haren here at Mount Sinai. I think Barry's off playing golf, but I think clearly he has more sense than I do. But I think that your analogy to Rolls-Royce is a very appropriate one. Rolls-Royce, of course, is only a $15 billion company, whereas Intuitive is a $20 billion company. So Intuitive is a much bigger organization than Rolls-Royce. Why is that? It's bigger because they sell $500 million of revenue every single quarter, which is a phenomenal amount of money which is going toward the robot. And when you've got outcomes which are essentially the same as laparoscopy, it's hard to really justify. Excuse me. I think that, when we talk about a lot of the differences with robotic surgery, you hear about the better visualization. If you like 3D visualization, you can get that same visualization with buying a 3D laparoscope to use with straight laparoscopy. If you feel that you're getting better function in small spaces, I really think that a lot of these advantages which are touted are somewhat imaginary. Certainly in terms of the ergonomic advantages, I think that you're trading off one set of difficult ergonomics for a different set of difficult ergonomics because you're sitting at a console which, frankly, after it's sitting at it for 3 or 4 hours can get pretty darn uncomfortable. In any case, I think that we do need more data, but the data that we have right now suggests that if there is a benefit, it's a minimal benefit, and do we live in an environment where we can afford $500 million every quarter to pay for this technology?
Okay, thank you very much. Next, we will try Cleveland Clinic Weston in Florida.
Can you hear me? Yes. I
Yes,
have
we
to
can
agree
hear.
with Dan. I think this is Sam Somstein from Cleveland Clinic, and we are not much friendly, at least in foregut surgery, with the robots either. I think this is an industry-driven technology. I think instead of looking for Rolls-Royce, we should be looking for Fords that can perform like BMWs. And honestly, I'm always tired of listening this comparison with the laparoscopy and robotics. Laparoscopy within 10 years was already established as a very beneficial and clear-cut new technology. Robotics, not only you have to pay to learn how to use that technology, which is the only thing that I've ever seen, so this tells you already this is kind of a business, but also you have, for 10 or 15 years, you keep pushing for a tie. A tie seems to be good enough for robotics, and that to me seems to be a problem. If you're gonna bring a new technology, please make sure you win, not tie. Tie is not good enough. Not only that, but we're assuming that we just stop doing anything in laparoscopy, that there is no better technology in laparoscopy, that there are no better instruments in laparoscopy. Laparoscopy itself is evolving to better. So you have to see that, and really the resources should be put into that instead of keep pushing for a tie or something that obviously seems to be more of a business, at least in the foregut surgery.
Okay. I think Wisconsin is also connected. I was wondering if Kirk Ludwig whether he's there or not. If he is, would like to get some of his comments. Good morning, Kirk.
Oh, good morning, guys. Yeah, I enjoyed both of those presentations. Tony, your thoughts are always compelling. And as a group, we have these discussions all the time. I do laparoscopy. I do a small amount of robotics. I have to say, in the depths of the pelvis, the robot, the visualization is really excellent. The way you can move your instruments is very nice. It is nice to sit down at the robot. There are a lot of nice things about it. Having said all that, I completely agree with Tony that it's just from a cost standpoint and from an outcome standpoint, it's a little bit hard to vigorously make the case for the robot at this point. That might change, but I say at this point it is. I have to fall slightly on the side of Dr. Senagore here.
Thank you, Karen. Thank you. Fair enough. How about Duke? Is Duke University still online?
Can you hear us?
Yes, we can.
This is Dana Portnier. We do robotics here in part of our minimally invasive bariatric fellowship program. And for me, I would say it's one of these things that, we've looked at it financially, and it's $1,000 extra per case. So it certainly makes it tougher to justify, and our health system actually clamped down on the use of robotics and is now only allowing us to use it for certain selective procedures based on financial margins. Having said that, though, I enjoy using the robot, and I think it's clearly of interest for trainees, and so I don't want to beat up on it too much because of what I think it has to in store for us in the future. I know there's lots of competition coming, and I think that's going to drive down cost and hopefully provide some of these benefits that we haven't fully realized up to this point.
Thank you very much. Here at the Cleveland Clinic, there are a couple of surgeons of us does a lot of robotic surgery as well, but we do agree with both sides. There are pro and con arguments for that. I will ask also my colleague, Megan Costidio, who does a lot of robotic surgery as well, and get her opinion on this topic.
So I agree with both sides. I think that we need to address the cost, and I think probably as societies go to intuitive and try to drive down costs, because certainly this is a company that is making a lot more than the rest of the companies. On the other hand, I think that it has been pretty pervasive in the comments that the surgeons are more comfortable, and that's not a measurable thing that we look into. And there are some studies that show muscle memory and muscle twitches, and for sure the robot is much easier on the surgeon. And so maybe if I get 5 more years, maybe then the robot was worth it. But I don't know, if we'll ever get that. For sure, technology is being driven further and further, and we will see some benefits, whether it's a robot or whether, as Dr. Senagore said, a true robot that can operate while we sit at home, and then we'll all be much happier. We'll see.
Yeah, Megan, as a truly advanced laparoscopic surgeon like you are, where do you see the robots filling in within your specialty of colorectal? Do you see it primarily in the pelvic area where you see the biggest advantage, or do you think it's going to spread into the abdomen as well, and will a high percentage of colon procedures be done robotically in the near future?
So I think the first place that, just as Dr. Senagore said, is the transanal TME. We can do that laparoscopically or through TAMIS or TEM or any of the platforms we use, but we can't get up into the abdomen with those strategies. And so if we have a robot that can go up and then we can transition and then do the abdominal portion of the procedure through the anus, potentially, again, do we need this or not, but we have incisionless surgery. We oftentimes need to divert for these low anastomoses, but certainly as technology advances, there will be a point, I think, where we do incisionless surgery. I think it's a little ways off, but that's the benefit, I think, of the robot for us. Until technology advances, because most of us, or a lot of people doing a lot of advanced laparoscopy, are using a lot of vessel sealing devices, and certainly the robotic technology for that is a little behind. So I think for us to switch to all abdominal robotics, we don't have the same instruments that we would use laparoscopically that we may like, and so it does take longer, and there is maybe a little more blood loss in the abdominal portion. But certainly the pelvis, it is a very nice procedure, and I have control of 4 hands, or the camera in 3 hands, versus having camera in 1 hand or 2 hands, and then having to count on other fellows or trainees. And then the trainees have the same benefit where I can assist. So I think that the deep pelvis right now is the benefit, but certainly in the future is going to be doing more through the anus.
But that really is an important area, but it's a niche area. It's probably less than 10% of all colorectal procedures, correct?
Yes,
yeah,
correct.
Yeah. I would just add, and sort of piggyback on what Dr. Portnier Duke had said, in other specialty areas, there's already pretty high penetrance of advanced laparoscopic surgery. Bariatric, for example, in my area, we have about 98% penetrance for all of the bariatric procedures, whether it's a gastric bypass, sleeve gastrectomy, even duodenal switch. They're all done almost completely laparoscopic, except for the rare patient or revisional case, and many other areas. And I think colorectal, you're probably now around 40% or so of colon operations are done. I mean, just nationwide.
Yes.
Nationwide.
Yeah, we're
I know
up.
here it's much higher.
Yeah.
Nationwide. So maybe there's an opportunity in colorectal that the robot could improve that penetrance. You have to look at the data, critically, and you just really wonder what clinical benefits are the patients, receiving. Pretty soft, it seems, based on the current technology, but we'll have to see what happens in the near future.
Yes. Yeah, as we all said, as technology evolves and new devices and instrument refinements come to life, surgeons will find new ways to do better, maybe better operations and provide better care for our patients. And with this, we will conclude our.
Why don't we have our two speakers just give their final?
Yeah, sure,
comments? That would be great.
Any last words from Dr. Senagore or from Dr. Safar? We'll go to Dr. Safar first.
Thank you.
Any final comments?
Thank you. I've enjoyed the discussion. I do think the technology is here to stay. I think it offers probably a bridge to different things, as we heard. Maybe one day we can do all node surgery because of the robot. It is more expensive today, so we have to justify it. And I look forward to more competition in the market from different companies.
Absolutely. Thank you. Thank you very much, Bashar. Dr. Senagore?
Well, I think there may be an opportunity for real robotics in the future, but we don't have robotics now. We just have a different device to drive the laparoscopic instruments. So it may be something out there in the future, but it won't be this thing.